to be a little bit over 100, so a big crowd today. But first of all, I wanted to welcome you all to the webinars, one of the webinars organized by the European Burden of Disease Network. I guess most of you are familiar with the network since we have been presenting it and introducing it many times in the last webinars. And today we have a special collaboration between the network and the Best Cost project, which Juanita Haagsma is going to introduce a bit more and give a bit more details afterwards. Yeah, today we're going to talk about exposure response functions for air pollutants and environmental noise. And to cover this very big and comprehensive work, we have 5 speakers, which is a bit different from what we have in the other webinars. And also, yeah, the webinar today will last a bit longer because indeed it's a very complicated topic. So today with us, we have Juanita and Tessa from Erasmus MC in the Netherlands. We have Hamid, Hassen from VITO in Belgium. Mariana Corda, hi Mariana, thank you for joining, from Egas Moniz Center in Portugal, and Pericles Haralampus from UCL in Belgium. So as you see, it's a very diverse and international speakers panel today, and all the people that you will hear today are part of the Best Cost project. Yeah, before starting with the actual content of the webinars and the results of the literature reviews, I'll give the floor to Juanita to explain to you what is the Best Cost project.
Thank you so much, Vanessa. And let's put it on the share. I hope you see the presentation now in presentation mode.
We see a black screen, but
okay.
Yeah, now we can see it. It's perfect.
Yes.
Yes.
So welcome to the webinar. I'm really happy that so many people are able to join us today. So I'm going to talk a little bit about the Best Cost project, because the exposure response functions that will be presented later in this webinar were established for the Best Cost project. And Best Cost is a large 4-year research project that was funded by the European Union, and 18 institutes collaborate in this project. And below in the slide, you see all the logos of all the institutes that are collaborating for this. And Cienzano, of which Vanessa is also part, and Brecht are leading Best Cost. So Best Cost aims to improve the methodologies for assessing the socio-economic cost of environmental stressors. So it has a special focus on long-term exposures to ambient air and also environmental air noise pollution. So it's about air pollutants and also noise pollution. And the socio-economic cost, it's a little bit of a vague container concept. It includes the burden of disease, so DALYs, disability-adjusted life years, but also transforming the DALYs into euros, so also the cost, the economic costs of environmental pollutants. And this is also referred to as the environmental burden of disease. So the DALYs due to environmental stressors are referred to as environmental burden of disease. Best Cost also includes a couple of case studies that are being done. So the environmental burden of disease of these case study countries is also calculated for Best Cost. All right, so environmental burden of disease, I already mentioned it a little bit. Environmental burden of disease is a concept that was introduced by the World Health Organization. And the aim of environmental burden of disease is to quantify the impact of environmental risk factors on population health in a comprehensible and comparable way. So, for instance, environmental stresses can be ambient air pollution, but also environmental noise. And these adversely affect human health, for instance, by increasing the risk of chronic disease and mortality. And then the environmental burden of disease quantifies the health burden or the burden of disease resulting from exposure to these factors. So for instance, exposure to NO2 or ozone. And if you have the burden of disease or the DALYs because of these different risk factors, and you calculate the DALYs that are resulting from exposure to these risk factors, you can then also compare the DALYs, for instance, from NO2 to the DALYs from ozone or environmental noise. And you can also look at changes over time with environmental burden of disease. So you can actually see if there's an intervention that was included or implemented in a certain country. You can then also observe if there are any changes in the environmental burden of disease over time. So why am I talking about this? We are going to talk about exposure response functions. Well, actually, exposure response functions are needed to calculate the environmental burden of disease. So calculating the disease burden attributable to an environmental risk factor involves several types of input data and steps. And this includes information on, for instance, how many people in a population are exposed to a risk factor. So this is in A, the little A picture that you see here, population exposure. But you also need information on the exposure response function. So how much exposure to a certain risk factor is needed or is minimally there when somebody gets a higher risk of getting, for instance, a chronic disease. So the exposure response function describes the mathematical relationship between exposure to an environmental stressor such as ozone or environmental noise and the associated risk of a specific health outcome. And it's based on epidemiological studies. So using the exposure response data, the exposure response function, and also the population exposure data, so from the data from picture A and B, we can calculate the population attributable fraction. And the population attributable fraction, so that's picture E, or that's picture D, sorry, that's the proportion of ill health or death that could potentially have been prevented if people were not exposed to NO2. Or if you reduce it to a minimum level, because some risk factors cannot be reduced to 0, they will be reduced to a lower level. And that's all. So in this webinar, we're going to focus on these exposure response functions and newly established exposure response functions that are then needed to calculate the environmental burden of disease. So here again, one small picture of the population attributable fraction. It's a proportion of ill health or death that could be potentially have been prevented by removing the risk factor or reducing it to a minimal level. And that's shown here in this really nice picture. That is not from me, that I got from a presentation from Susanne Breitner. But here you can see then in a way which part of the burden of disease can be prevented if you remove, for instance, exposure to noise or exposure to NO2. So for best cost, one of the aims was to establish new exposure response functions to establish the environmental burden of disease, for instance, for the case study countries that are also done in best cost. And the new exposure response functions are exposure response functions for ozone and asthma, for PM2.5 and lung cancer, for NO2 and chronic obstructive pulmonary disease, transport noise, road, railway and aircraft noise, and ischemic heart disease, and transport noise and stroke. And these are based on, so exposure response functions are based on systematic literature reviews. And in total, and this is something I really want to highlight, in total for this, so to achieve these exposure response functions, more than 11,000 records have been screened. And more than 90 studies were included. So the presenters in the next slides have contributed hugely to these exposure response functions, because they had to go through all these studies to actually get to the exposure response functions. Okay, so in the next hour, we will first have a presentation by Tessa Haverkate from Erasmus Medical Center on the exposure response function of NO₂ and chronic obstructive pulmonary disease. Then we will have a presentation by Hamid Hassen from Belgium, from VITO, on ozone and asthma. Then we will have some time for general discussion and question and answering. Next, we will have a presentation on PM2.5 and lung cancer and the exposure response function. This will be done by Mariana Corda from the Egas Moniz School of Health and Science in Portugal. Lastly, we will have Pericles Charalampous, who is going to present about the exposure response function of traffic noise and cardiovascular disease. Then we have another general discussion and question and answering session, and then I will have some closing remarks. But first we will go to Tessa. So I will give the word now to Tessa, and we will have some questions and answering after the presentation by Hamid. Thank you.
Should I also share my screen? Yeah, so my name is Tessa Haverkate. I work at the Erasmus Medical Center in Rotterdam in the Netherlands, and I focused on the NO₂ and COPD risk outcome care. Chronic obstructive pulmonary disease is the fourth leading cause of death worldwide, causing 3.5 million deaths in 2021. COPD causes restrictive airflow and breathing problems. And in people with COPD, the lungs can get damaged or clogged with mucus and the alveolar membranes break down. Smoking and air pollution are the most common causes of COPD, and the Global Burden of Disease Study 2021 estimated that respectively 23% and 13% of the COPD mortality is attributable to ambient PM2.5 and ozone exposure. As of yet, NO₂ is not included as a risk factor in the GBD studies, and therefore the specific contribution of NO₂ remains to be quantified. NO₂ is a pervasive air pollutant introduced to the air by the oxidation of nitric oxide during combustion. And anthropogenic emissions of NO₂ are primarily attributed to the burning of fossil fuels, such as in motor vehicle exhaust and coal-fired power plants. Juanita already explained this and also showed the same picture, but exposure response functions are essential to quantify the health impact of risk factors and to inform policy about acceptable levels of exposure. So exposure response functions show the model predicted mean level of the response variable in a population for each level of the exposure variable. And like Juanita said, by combining the exposure response function with the population exposure data, the population attributable fraction can be derived, which form the basis for calculating the disability adjusted life years attributable to pollutant exposure. And to derive an exposure response functions, estimates from different epidemiological studies can be pooled. So the first aim of this study was to provide a comprehensive overview of existing evidence regarding the association between long-term exposure to ambient NO₂ and COPD outcomes. Therefore, we conducted a systematic literature review in which multiple electronic databases were searched twice to identify suitable articles. We included cross-sectional and cohort studies, which focused on the general human population. And for COPD, we looked at incidence, prevalence, and mortality. And for NO₂, we looked at long-term ambient exposure. So this means that we excluded COPD exacerbation, and with regard to NO₂, we excluded short-term exposure, occupational exposure, and studies that used NOx as a proxy. After screening of over 2,000 reports, 24 were included. Half looked at COPD mortality and half were conducted in Europe. The mean NO2 exposure was much lower in Europe compared to all the studies combined. Next, we performed a random effects meta-analysis to pool the individual estimates. Relative risk indicated a positive association between long-term exposure to ambient NO2 and combined COPD incidence and mortality. For all studies combined, the pooled relative risk was 1.04 with a 95% confidence interval of 1.0 to 1.09. And when pooling just the European studies, we observed a higher risk estimate, namely 1.08 with a confidence interval of 1.01 to 1.15. However, for both of these estimates, we see high heterogeneity indicated by the I-squared and inconsistent COPD definitions, exposure assessments, and unaccounted confounding factors likely attributed to this variability. As I explained, the exposure response function is essential to quantify the health impact of a risk factor and to inform policy about acceptable levels of exposure. So the second of this study was to derive and compare exposure response functions of the NO2 COPD association using two different meta-regression approaches. The first approach we applied was the natural cubic splines approach. Splines are piecewise polynomials that are connected at each point, which allow the curve to be flexible. The second approach we used was the meta-regression Bayesian regularized trim, also known as the Mr. Bird. In this approach, the 10% tails are excluded, and in contrast to the more conventional approach, the Mr. Bird only considers the monotonic behavior of the shape. And as these methods adhere vastly different assumptions, we expected the curve to have different shapes. For all regions combined, we saw that the variable exposure data combined with the differences in estimated effect size resulted in a fluctuating exposure response curve when using the natural cubic splines. In the Mr. Bird model, the shape flattened out, which aligns better with theoretical expectations. Our third objective was to derive and compare region-specific curves for Europe. And similar to global data, each approach produced a different exposure response function with the European data. While the natural cubic splines resulted in a U-shaped curve, the regional Mr. Bird showed a progressive risk increase. This study highlighted the complexity of establishing the relationship between long-term ambient NO2 and COPD outcomes. While our review and meta-analysis observed a positive association between long-term exposure to ambient NO2 and combined COPD incidence and mortality, considerable heterogeneity across the studies complicates definitive conclusions. Inconsistent COPD definitions, exposure assessments, and unaccounted confounding factors have likely contributed to the variability we saw. And the comparison of exposure response functions derived using conventional meta-regression and the Mr. Bird demonstrated how methodological assumptions can influence the interpretation of the COPD-NO2 relationship. This has implications for disease burden assessments. And lastly, we saw evident regional differences, which underscore the need for further tailoring exposure response functions. And to improve the relevance and applicability of exposure response functions, methodological choices should align with the available exposure data, regional exposure patterns, the expected shape of the exposure response relationship, and the objective of the analysis. Thank you for your hearing. And I think I'll hand over to Hamid now.
Can you see my screen now?
But it's not in presenter mode. Yeah, that's perfect. Thank you. Thank you, Tessa.
Okay, good morning, everyone. I'm going to present specifically long-term exposure to ozone and the association with asthma. Ambient air pollution remains a major modifiable environmental stressor. According to World Health Organization limit, 9 out of 10 people are exposed to harmful levels of air pollution, which exceeds the WHO limit. And 7 million people are like related, their air pollution related premature diseases every year. And this number is expected to double by 2050. When we come specifically to ozone, 250,000 deaths are attributable to ozone exposure, and this number is 4 million when it comes to disability adjusted life years. There is an ample evidence the effect of short-term ozone exposure on exacerbation of asthma and also mortality related to asthma. However, the effect of long-term exposure on asthma remains unclear or not well studied. As a result, the attribution of ambient ozone exposure, specifically related to long-term exposure, is not be included in the global burden of disease studies because of lack of evidence. So this study aimed to provide an overview of existing evidences on the association of long-term ozone with asthma morbidity and mortality, and to quantify the association between ozone and risk of asthma. We conducted a systematic review and meta-analysis using different electronic databases supplemented by manual search of references, reports, and different systematic reviews. The exposure is long-term ozone exposure, which was defined as the highest seasonal or above 6 months of average of 8-hour daily maximum ozone concentration. And we specifically focus on outcomes, incidence, prevalence, and mortality. However, there are no many studies on mortality. There was only one study which is not included in the systematic review. We focused on 3 study types: cohort, case control, and cross-sectional studies. And we also performed a subgroup analysis only considering cohort studies. We used double title and abstract screening. We used the JBI tools to assess the quality of the studies. And we used a data extraction form that's provided by IHME. We performed 2 different meta-analysis methods. The classical meta-analysis using random effects models. We did the heterogeneity assessment. We performed subgroup analysis using only cohort studies, and also we assessed the publication bias. And there is also another modeling, the meta-regression Bayesian example regularized trimmed model, or Mr. BERT, which is a method used in different global burden of disease estimations. The basic features for the Mr. BERT model are: 1, it uses a Bayesian framework, which enables to quantify the uncertainty. It combines multiple models to provide a more robust estimate. And it also uses penalization technique to avoid overfitting, and using of trimming for studies that are considered to be outliers with unplausible effect estimates. When it comes to the results, The database search resulted 5,947 studies, and with the addition of 21 using manual search. And finally, out of these, 39 articles of 29 studies were included, because a few studies, they have multiple publications out of the same data. The sample size range, like huge difference in the sample size from 608 until 5 million, which is really a huge difference in sample size across studies. 15 studies were cross-sectional, 9 cohort, and 5 case control studies. Different methods of exposure assessment were used, like predictive modeling, physical measurement, and also some few of them used satellite imaginary estimation of ozone exposure. And here we can see that the distribution of studies globally, and most of studies are like in the North America and also Asian countries. When it comes to the results, this is the result for the classical meta-analysis. First, we included all study types, cohort, case control, and cross-sectional studies. And we can see that there is a significant association between long-term ozone exposure and asthma. For every 10 microgram per meter cube increase in long-term ozone exposure, the risk of developing asthma rise by 2.6%. And we can see that there is a difference or heterogeneity in the effect size across studies. And the heterogeneity is also considerably high, which is 96% I-square. We performed a subgroup analysis considering only cohort studies, that are 7 studies, and the effect size becomes even more. There is a 5.7% increase in the risk of asthma for every 10 microgram per meter cube increase in long-term ozone exposure. And the findings or the effect sizes for each individual studies become more consistent compared to all study types. When you see the response curves, exposure response curves using the Mr. Bert model, using all studies, the first model, it shows that there was no significant association between ozone and asthma, but then they forced it to be monotonic and to be a positive association, because that was the hypothesis that we planned a priori. So the result becomes like there is a kind of association until 30 ppb of ozone exposure, then it becomes like almost constant. So that means the effect will not be changed after 30 or 35 parts per billion ozone exposure level. They also did the same specifically for cohort studies, and as we can see, the effect is a little bit higher than when we use all studies, and which shows that there is more likely there is a significant association between ozone and asthma, because cohort studies are considered to be better when it comes to assessing the causal association of exposures with the outcomes. And when we do specifically for children and adolescents, but using all study types, because we cannot only do a cohort studies, because number of studies will be very limited. And as we can see, the effect become more pronounced specifically for children and adolescents. However, due to lack of studies, the confidence interval is very wide, showing that the burden of proof risk function, which is the red line, is somewhat similar with for adults, children, and adolescents. So In conclusion, there is statistically significant positive association between long-term ozone exposure and risk of asthma. However, there is a considerable heterogeneity between studies. And subgroup analysis of only cohort studies showed even a stronger association, which might show that there could be an association between ozone exposure and asthma. So findings underscore the potential public health impact of reducing ozone exposure, and the exposure response function is valuable for estimating the burden of asthma attributable to long-term ozone exposure. Thank you so much.
Thank you, Hamid. So now we have 15 minutes for questions or suggestions or comments. So I'd like to give the word to the participants. Anybody, any questions about the presentations you just saw?
Yeah, just a note. So you probably the panel, sorry, the attendees cannot unmute themselves.
Oh.
So you can put your questions in the chat. I'm not sure if attendees can raise their hands, and I can give them the right to to unmute.
Yeah,
So
otherwise maybe it's easier.
Yeah,
maybe it's easier for the chat function to be used. I don't see any questions yet.
I see a hand raised. So let's see if it works. Yeah, Gerard, can
I ask the question?
Yeah, perfect. We can hear you.
Okay. Well, that was very impressive work. Thanks a lot. I have a question about the exposure response function. And the question is, how confident are you that you can assess the shape of the exposure response function based on what is published in papers without having access to the individual data? Or in other words, have you looked at how the exposure response within specific studies was, and whether that was any different from the shapes you were presenting? Thanks.
Yeah, Hamid, maybe you want to comment on this?
Yep. Actually, we don't have data from individual studies, but what we used is we extracted the level of exposure for each studies, and we see whether we included the level of exposure for each study in the model. Specifically for the Mr. Bert model, they include the level of exposure for each studies and the effect sizes. That makes a little bit into consideration, but we didn't construct the exposure response function for the classical meta-analysis specifically for ozone and asthma. I think for NO₂, you already performed the exposure response functions, but for us, we did not, because we're still looking which shape makes sense to use for exposure response function. We cannot use like linear or log linear. We need to decide first which association makes better. For instance, for you, I think you used the spline cubic, but we are not sure specifically for ozone. But for Mr. Bert, they include the level of exposure and the effect for each studies.
Do you want to add to this, Tessa?
No, I think it was a good answer. I saw a question in the chat asking if we have performed the Mr. Bird ourselves. No, it was indeed run by IHME. IHME is also part of the BEST project. So we all provided our data extraction sheets, and they ran the Mr. Bird models for us. And I think I can also answer Annette's question about the star rating. The star rating she refers to is sometimes provided by IHME, provide an easier to interpret measure of how good the current is. I personally did not receive rating. I think we have it for some of the other exposure response functions. Maybe Hamid did. I don't think so.
Yeah, I have the scripts for Mr. Bert. They already sent us the method they followed and also the scripts, but I haven't tried it on my computer yet. But yeah, I will definitely try it. But they sent the scripts to us.
Now, with script, Hamid, do you mean our package?
The scripts they used to perform the Mr. Bert model. They
And
already
we-
shared the scripts from the HME.
Yeah. Thanks. And then we have a question from Carl about the software that was used. Well, we didn't run the Mr. Bird model, so we don't have any R package or any example. So it hasn't been released from IHB to us, at least, not for best cost. And then we have a question of Catherine. Is it possible for you to send the studies to us attendance? It would be really interesting to read them and use them as inspiration for further focus on the topic. Well, this information, the exposure response function that are presented here are fresh from the press. So the results or the exposure response function have been finalized in December and January, past December and January. So the publications are not yet available. I see Hamid. Oh yeah, you see, yeah, a link to to Mr. Bird. But no, so we don't have the publications yet. I think a couple of the manuscripts will be submitted soon, and hopefully when they're available, we can maybe at least give a message on the European Burden of Disease Network website that they have been published.
Thank you. There is Heba that has his hand up. Do you want to ask your question, Heba? We should be allowed to speak. Okay, maybe we can go back to Heba later, but there is another question from Gerard in the chat. Did some of the studies provided multi-exposure models? Is NO₂ related to COPD after correcting for PM2.5? So is this included in the GBD?
We have the data.
This question or partly.
Maybe Tessa, you can
You want to go?
because it's about NO₂.
Yeah. So what I did in my review was select the estimate that was provided by each of co-pollutants. So sometimes this was PM2.5 and ozone, sometimes it was just PM2.5. I've also conducted a subgroup analysis for just studies that corrected for PM2.5. Yes, NO₂ was then still related to COPD, and heterogeneity was much lower subgroup analysis. Yeah, I hope this answers your question.
Thanks, Tessa. Do you want to add to this, Hamid?
No, it's just that we noted that whether they perform like multi-pollutant regression or not, and that was taken into account in the GBD estimation, but it's not like specifically whether it is PM2.5, NO₂ or ozone, but they said like if it is multi-pollutant model or single pollutant models, but that was taken into consideration in the Mr. Bird model. I see in the model, yeah.
Thanks, and I see that Heba has included a question in the chat function, and the question from Heba is, have you managed to compare the findings of your studies with the latest evidence, relative risk and CRF, generated by WHO for the WHO air quality guidelines? Can I give this question to you, Hamid?
Yeah, haven't compared it yet with the WHO air quality guideline, but I'm not sure whether they have the relative risk specifically for ozone. I don't think so, but that was the reason to perform this systematic review. So if there are an estimate, we really need to have check it. Yeah.
Thank you, Hamid. And then we have a question from Ulrike related to Gerard's question about two exposure models. O3, ozone, and NO2 are often negatively correlated, which may suggest protective effects of ozone. Did studies report two exposure models with NO2 and ozone? Yeah, I don't know. Did you already answer that question, Tessa? I don't know. I'll give it to you, the question.
No, not completely. There were not many studies included in the literature review that also included ozone. I think of the 24, there were about 5 that included ozone as a co-pollutant.
Thanks. And I don't know if Hamid wants to add to this because it's also about ozone.
Yeah, I think it's really exactly what we found in the first Mr. Perth model. That's definitely due to the negative association between ozone and NO2. It shows like there is a kind of protective effect of ozone against asthma. That was definitely what we found like in the first round of Mr. Perth model. But according to the hypothesis, they try to force it like a positive association, and it starts to come up like as a positive association. But definitely we observed that pattern also. So.
Thank you. Well, thank you both, Hamid and Tessa. And I think we can now move on to the, oh, I see one last question, maybe. Well, that's a long question. So I think we have to move on to the next speakers. So now we move on to Mariana and to Pericles for the other two exposure response functions. So thank you participants for the questions. And after the presentation of Mariana and Pericles, you will have another chance to ask questions. And if you have any afterburner questions about the NO2 or the O3, the ozone exposure response function, you can still also ask them in that block of questions and answers. Thank you. And I'll give the word to Mariana.
Thank you, Juanita. Good morning, everyone. So I will present my, are you seeing my screen?
Yes, it's not yet in presentation mode.
And now it is?
Not yet, but I think it's a bit slow in...
And now?
No.
No? Okay.
You need to share your entire screen and not.
Oh, okay. Thank you. Thank you, Tessa. So now you are seeing, yes?
Yes.
Okay, perfect. So good morning, everyone. It's a good pleasure being here presenting my results for our systematic literature review and meta-analysis about long-term exposure to ambient PM2.5 and lung cancer. So as we know, lung cancer is the leading cause of cancer incidence and mortality globally, with 2.5 million people diagnosed with lung cancer and more than 1.8 million people died from the disease. The lung cancer globally is responsible for around $46.5 million, and in Europe is responsible for around $9.8 million. This health condition is affected not only by non-modifiable or partly modifiable risk factors, but also is affected for modifiable risk factors, such as pollution. And we know that in Europe, more than 10% of cancer burden may be caused by exposure to air pollution and other environmental and occupational determinants of cancer. And we know that particulate matter is the leading risk factor for human health. The ERC have been classified PM as a group 1 carcinogen that indicates that no limit value for PM have been established below which health effects are not observed. And we know that PM with a diameter of 2.5 micrometers or less is one of the air pollutants more harmful to human health. So, given the impact of PM 2.5 to lung cancer incidence and mortality is not well quantified, we had conducted a systematic literature review and a meta-analysis to drive exposure response relationship that reflecting the relationship between lung cancer incidence and mortality case as function of exposure to ambient PM 2.5. And to address this main objective, we need to answer 2 questions. What is the relationship between PM 2.5 and the incidence and mortality of lung cancer? But also if the exposure to PM 2.5 is associated with an increase of the risk of developing lung cancer. And to accomplish that, a team of several co-authors has involved, coordinated by Dr. Ricardo Assunção. So, to accomplish the main objective of this study, we firstly conducted a systematic literature review using different databases, and for that, only studies that describe an association between long-term exposure to ambient PM 2.5 and incidence and mortality of lung cancer using a relative measure of association was included. And the studies need to be published over the year of 2010. After that, we had extraction data for the studies included and moved forward to the meta-analysis, where we had made 2 types of meta-analysis, 2 models, a classic one commonly used on WHO studies, and a more robustness used on GBD studies to establish an exposure response function. As a resulting of the systematic literature review, we had screening 2,215 studies, and we had only included on our analysis 27 studies. Of those, 9 studies were conducted on European region. About the results, and given the smaller number of European studies, the results have only been presented at a global level. So for the classic meta-analysis results, we have found an increased risk of lung cancer incidence by 11% for an increase of 10 micrograms per meter cubic of the exposure to PM 2.5 with a statistical significance for both sexes. And when we look for the results for lung cancer mortality, we had also found an increase of the risk of lung cancer mortality when we have an increase of 10 micrograms per meter cubic of the exposure to PM 2.5 by 14%. When we look for the results for the meta-analysis model more robustness, the Mr. Bird, we estimated the effect size for PM 2.5 exposure on lung cancer mortality and incidence, risk in 1.6 with a risk score very low. And we have a star ranking of 2, which means there is significant evidence of association. And this star ranking is useful to guide policy decision making. When we're looking for the incidence results, we had estimated a smaller risk of developing incidence lung cancer, but we have also a star ranking of 2. Wherever, when we're looking for the mortality results, we only have a star ranking of 1. That means no significant association between the risk factor and the risk of the health outcome was found. So finally, our study provides the robustness evidence that PM2.5 exposure increased the risk of lung cancer with statistical significance, and given this result, the next steps should include a comprehensive analysis to estimate the long-term impact and the costs due to this exposure on lung cancer, incidence and mortality that will support the evidence-based policies updates and support the development of preventing and intervention programs. Thank you very much for your attention. If you have any questions, you can email me or do it now. Thank you.
Thanks, Mariana. And now we will go to Pericles. And now we move on from air pollutants to environmental noise.
Do you see my screen or not yet?
Yes, but not yet in presentation mode.
Okay.
Yes.
Okay, thank you. So hello everyone, my name is Pericles Haralambous and I work as a postdoctoral researcher at the University of Leuven in Brussels, Belgium. Before I begin my presentation, I would like to thank all the members of the Best Coast Task 1.1 and 1.2 activities, because what I'll be presenting you today is not only my work, but is more a product of collaborative efforts. So the fourth systematic literature review of the Best Coast is to derive exposure response functions for traffic noise and major cardiovascular diseases. This was driven mainly by the rationale that the 2018 environmental noise guidelines for the European region included studies conducted between 2000 and 2015 and provided limited evidence on the association between transportation noise sources and major cardiovascular disease outcomes. However, from 2015 onwards, several population-based studies have been performed to explore these associations, leading to not only different results, but also different strengths of evidence. So we aim to conduct a systematic review incorporating both a qualitative synthesis, meaning systematic literature review, and quantitative synthesis, meaning meta-analysis and meta-regression of existing evidence regarding the association between long-term exposure to transportation noise sources, meaning road traffic, railway, and aircraft noise, and non-fatal and fatal cardiovascular disease outcomes. By non-fatal, we consider only incidence, so we excluded prevalence, or let's say cross-sectional study designs, and by fatal, I mean mortality. Major cardiovascular disease outcomes, we consider ischemic heart disease, stroke, and myocardial infarction. For today and for the stroke, we also consider the subtypes of stroke. But for today, in my presentation, I will show you results only on myocardial infarction and stroke, because looking at the time, I have only 10 minutes. And our second aim, of course, was to derive exposure response functions for these risk outcome pairs. For example, myocardial infarction, road traffic, etc. Regarding the methods, we have two parts. On the left side, you will see the qualitative evidence synthesis, and we followed, for the systematic review, we follow the PRISMA guidelines and searched in 6 bibliographic databases and 1 search engine, which is the Google Scholar. We included cohort and case control studies that reported on the noise exposure level, and that was the 24 average sound level, referred to as the day, evening, and night noise level, the L10, and studies that defined how and when the exposure was measured. We also consider studies that quantified the relative measure of the association or the number of cases and non-cases among the exposed groups versus the non-exposed comparators. We screened over 2,300 studies, if I remember correctly, and extracted data from 26 unique studies. And then we also assess the risk of bias using the Newcastle-Ottawa scale for both cohort and case control study designs. For the quantitative evidence, this is the right part of my slide. We ran the meta-analysis and the meta-regressions, and we observed that the risk measures were reported in varying formats, and that was the categorical versus the continue values. And to ensure consistency, we standardize these measures by converting the categorical data to a common 10 decibels increment, and then scale them to midpoints to the L10 indicator that we consider. For the conventional meta-analysis, we used both mixed and fixed effects models, and we assessed in between study heterogeneity. And of course, to derive exposure response curve, we applied meta-regressions. For the Mr. Bird, we followed the GRADE guidelines, and we also assessed in between study heterogeneity. We also use the burden of proof risk framework, meaning that each risk outcome pair assigned to a score and further to a star. These stars is 1 to 5. For example, a 1-star risk outcome pair indicates a weak evidence of the association, whereas a 5-star risk outcome pair indicates a strong evidence of the association. Here I present the results for the myocardial infarction and per transportation noise source. This is in the first column, the road traffic noise, in the middle, railway, and on the right, the aircraft noise. For conventional meta-analysis, we found a 2% increase in risk per 10 decibel for myocardial infarction, associated, of course, with road traffic noise, and the relative risk was 1.02. A 1% increase in risk for myocardial infarction and railway noise with a relative risk of 1.01, and 2% increase in risk for myocardial infarction and aircraft noise with relative risk of 1.02. However, the pooled estimates were statistically significant only for 1 out of these 3 risk outcome pairs, and that was for myocardial infarction and railway noise. What we see in this figure for conventional meta-analysis is that the exposure response functions for both road traffic and aircraft had a relatively stable pattern across the noise exposure range, whereas for railway noise, we see a more pronounced increase in risk, especially from 16 decibel and above. For the Mr. Bird analysis, we found that the strength of evidence ranges from 1%, from at least 1% increase in myocardial infarction given the exposure to railway noise, and the burden of risk proof was similar to the conventional meta-analysis, was 1.03. We also see 8% decrease in myocardial infarction given the exposure to the road traffic noise, and the burden of proof risk function was 1.03. In the next slide, you see you see a table summarizing the results for conventional meta-analysis and Mr. Bird. And here you see that the statistically significant result was only for myocardial infarction and railway noise. And we see also a 2-star rating system for 2 risk outcome pairs, and that was for myocardial infarction and railway noise, and myocardial infarction and aircraft noise. For stroke, we found no association with railway noise and an increase of 1% risk for road traffic and aircraft noise. However, again, none of the pooled estimates were statistically significant. What we see in these figures is that the exposure response functions for stroke and road traffic noise increase gradually across the exposure range, whereas we see a more sharp increase above, again, 16 decibels for the railway noise. For the Mr. Bird analysis, we found a 2-star rating for road traffic noise, and that the shape, again, for aircraft noise is very similar to the one of the conventional meta-analysis. Here you also see a table summarizing the risk outcome pairs for stroke, road traffic, railway, and aircraft noise, and you see only a 2-star rating for stroke and road traffic noise. For the conventional meta-analysis, you see that none of the results were statistically significant. Overall, we found that the strongest and significant evidence was found only for railway noise and myocardial infarction. And we also found that the relationships between road traffic, railway, and aircraft noise and myocardial infarction and stroke were overall non-linear. It should be noted that the nature of these meta-analytical approaches, in this case, meta-regression, conventional meta-analysis, and Mr. Bird, can really influence how we interpret the transportation noise effects on myocardial infarction and stroke, particularly in the exposure-response relationships. That was my presentation, and yeah, I would like to thank you very much, and I welcome any questions you may have. Thank you.
Thanks so much, Pericles, for this presentation, and I want to thank all of the presenters for keeping so well to time with all the results that are being presented. I also want to acknowledge Elia Gonzato's contributions, particularly to the noise exposure response functions. I know he's among the participants, so that's also very nice that you can join us here today, Elia. All right, so we have some comments and questions. So we now have again 15 minutes for questions and comments. The first one is from Catherine, and it's about using LDEN noise indicator. You make the assumption that people are outdoor, but people are mostly inside buildings. I don't know if you want to comment on this, Pericles.
Sure. One of the goals of the Best Coast project is to at least for task 1.2 was to, which I forgot to say this, was to measure outdoor exposure. So we didn't consider any indoor exposures. And also the difference for long-term and short-term exposure. We only consider long-term exposure.
Great, thanks, Pericles. The next question is, how will you use exposure response functions calculated by Mr. Bird to obtain attributable cases? I don't know if Mariana wants to take this question, or I should give it to someone else.
I think we can use the results as a relative risk, I guess. And we need to estimate the population attributable fraction, as Juanita had said in the beginning of this session. And after that, we can multiply the total burden per this path, and we have the attributable fraction, the attributable burden related with the risk factor.
Thanks, Mariana. Yes, and then we have a question from Matthias Lochman. Hi, Matthias. Nice that you join us today. It's a question for you, Pericles. Could you comment on the outcome selection of the environmental noise exposure response function? It differs somewhat from the European Topic Center report. They included, for example, annoyance and all-cause mortality.
Yes, thank you, Matthias, for the question. The task 1.1 activity came up with disease models, and then we prioritize which health outcomes have more evidence or strong evidence, or the need to prioritize exposure response functions. For both, if I remember correctly, noise annoyance, but also sleep disturbance, the evidence was and also the quality was very limited. So we decided not to prioritize these risk outcome pairs, at least at this stage. It doesn't mean that exposure response functions cannot be derived, but for the best cost, we consider or we prioritize different risk outcome pairs.
Thanks. And then the next question is also for Pericles. Thank you, from Athanasios. Thank you for your presentation. Do you aim to derive new exposure response functions for annoyance and sleep disturbance as well? I think you already touched upon it a little bit.
Yeah, at this stage of best cost, I don't think annoyance and sleep disturbance are a priority because, yeah.
Thanks. Yeah, we already, or you already screened more than 11,000 papers to establish these 4 exposure, or these 6 exposure response functions, I should say, including all the noise ones. So yeah, we didn't have the resources to do all the health outcomes that were causally linked to any of the risk factors. So that's why we had to make some choices about those. All right, and then we have a comment from Gerard, because he says that the European Environmental Agency has done a review as well for noise, and you included the citation. Thank you very much, Gerard, for providing this information. Yes, and then we have a question from Ingrid. Thanks, Pericles. Did you separate between incidence and mortality in your exposure response functions?
Yes. However, the out of these 26 studies, I think 3 or 4 were mortality specific. So most of the evidence was focused on the incidence. For conventional meta-analysis, we did several subgroup analysis, including incidence versus mortality. But for the Mr. Bird, we combined both in one model, incidence and mortality.
Thank you. Any other questions? I don't see any more in the chat. Anybody have any questions now after, maybe some afterburn questions for Tessa or Hamid on the ozone for NO₂?
I maybe have a more general question because you showed the difference between the two methods, so Mr. Bird and the classical meta-analysis. So after having gone through the methodology, do you have any conclusions, any comments that you would like to make between the two methods to favor one or the other, or to maybe bring some disadvantages in one or the other?
Yeah, who of the presenters wants to comment on this first? Maybe Hamid?
Great. Thank you, Vanessa. The first thing is for the Mr. Bird, I have to rerun it on my machine first before I give comments, because there are a lot of things that we are not in control. So I really need to check first what's going on. For instance, for trimming, there are a few studies they trimmed. So I really need to see what the reason for trimming. For instance, they trimmed like one study with 5 million participants. What could be the reason? So would be nice first to rerun the analysis in my machine, and I can give like an overall comparison which method could be the best. The problem with the Mr. Bird is I think they just send the results. They send the methods what they used, but there are a lot of things, especially which coverage did they control, how they control for multi-pollutant results and single pollutant results. So I need to check those first. Then I think I can we can give a conclusion which method can be best. When we see like the general overview, that Mr. Bird model looks better because they try to consider a lot of things, but I'm not really very sure because I really need to see and to rerun the analysis in my machine. That's my my feeling.
No, but it's a good point indeed, like having control and understanding what's happening behind. It's a really good point to favor one method. I see that Gaio has a hand up, so I'll request to unmute and you can ask your question. If this works. Yeah, Gaio? Hello? Yes, perfect. We can hear you.
Yeah, thank you so much. I just had one very quick question regarding how long the exposure had to be in order to be able to, actually say that I have a level of impact, etc. So how long it's gonna take? How, because I have missed that in the presentation. How many years, how many months, etc., of data that are relevant before to say, okay, this is sufficient and we can actually relate the noise exposure and, let's say, a particular disease, etc. For instance, the one you have. So I'm clear in my question.
Can I give the question to you, Pericles, since Galio talked about noise?
So he's talking about noise or in general?
In general, but maybe you can give a comment in general.
Sure.
Yeah, if that's okay.
Yeah, I think this depends on some case definitions. I'm not sure to say exact like 4 or 5 months, but I would assume that a period lasting from several months to year to consider it a long term. Whereas short term refer to me hours or days or 1-2 months. Yeah, that's it. I'm not sure if somebody else wants to say something different.
Thanks, Pericles. Maybe, I don't know if Tessa or Mariana want to add to this?
Yeah, normally a long-term exposure is 1 year, but like for short term, it's like hours or days. It's a short period of time. But for long term, we normally consider 1 year of exposure.
Mm.
For ozone, we used 6 months average. It should be measured at least for 6 months in order to be long-term ozone exposure.
Tessa, do you also want to add to this about the COPD?
Oh, I think it's similar to what has been said before. It does, however, add to the variability between studies, that different studies use different exposure windows. Some use 1 year annual average, some multiple years. So yeah, adds to the uncertainty of our results, I think.
Thanks. And I see a comment from Gerard, who says very good comment. I don't know which one, so I guess it's for all of you, the compliment. For a small number of studies, it would make me nervous to see very different results from the 2 approaches. So Mr. Bird and a more classical analysis. Maybe best to treat as a robustness analysis rather trying to assign a best approach. So I think this replies very much to your comment, Hamid, that you talked about. We do not know the truth, and that's a fact. We do not know what the gold standard is here, so we have to make some choices. But it's good to be aware of the differences in results, or maybe not differences in results, but it's good to compare the results of the exposure response functions that have been done with 2 different approaches and actually the same study, so that we can see which part of the variation can be contributed to the approach rather than to including different studies. But thank you very much, Gerard, for your comment. I think this is the end of the session. So I have some last concluding slides. I'll share those now. So this concludes the last session of the questions and answering. And now I'm going to share the last slide. Let me see it. Can you see it already? No?
Not yet, Juanita.
Okay. All right. I'm sharing it now. Oh, am I sharing something now? Yeah, I think
Yeah.
so. Okay. So for the best cost, we have some upcoming events. So later in 2025, there will be some stakeholder workshops on best cost R packages to quantify the burden of disease. So these are several workshops to test the R package for burden of disease assessment, health impact assessment, or policy evaluations, which might be interesting for you to attend as well. If you or your colleagues are interested to take part in these, you can send an email to this email address. Maybe one of you can share it. Oh, I can share it in the chat function as well. Do not hesitate to share this information. If you want to keep updated on the activities and the results from Best Cost, you can also sign up to the newsletter, where you can also see the email address here. So what rests me now is to thank you all for participating. I want to thank Vanessa, Laila and Brecht for organizing this webinar. And I also want to thank Tessa, Hamid, Mariana and Pericles for presenting today. And of course, also for all best cost members who contributed to establishing these exposure response functions, because it took a lot of effort to get to this result. So thank you all very much. I also want to thank all the participants for the participation in this webinar, and I hope you enjoy your day today. Thank you.
Thank you very much, and see you soon in the next webinar. Bye.
Thank you. Bye-bye.
Bye.
Thank you. Have a nice day.
Good job, everybody.
Thank you.